Sir Michael Marmot is Professor of Epidemiology at University College London, Director of the UCL Institute of Health Equity, and past President of the World Medical Association. He's led research groups on health inequalities for over 40 years, and is the author of, amongst others, The Health Gap, The Challenge of an Unequal World. Michael, our session introduces today looking at healthy cities, especially in terms of what we can do to provide solutions over the long term. Your review, Fair Society, Healthy Lives, was published 11 years ago. The mission of your institute is nothing less than a fairer, healthier society. Can you tell us a little bit more about the key points from that first area of work?
We were asked to look at how the global recommendations that I made as chair of the World Health Organization Commission on Social Determinants of Health could apply to one country, England, because what you do in India and sub-Saharan Africa may be similar in concept, but rather different in particular to what you would need to do in European countries. We reviewed the evidence and we said that health inequalities are not inevitable. The systematic inequalities in health between social groups can be avoided, which is why we talk about health equity. That's the avoidable health inequalities. And the implication of saying health equity is that these avoidable inequalities, if they're not avoided, are unfair and are unjust. But we didn't just beat the table with a clarion call for social justice. We did do that, but we gave practical recommendations on what you could do to achieve it, to achieve a fairer distribution of health. And there were 6 domains of recommendations. Give every child the best start in life. Number 2, education and lifelong learning. Number 3, employment and working conditions. Number 4, in a rich society, everybody should have at least the minimum income necessary for a healthy life. Number 5, highly relevant to cities, healthy and sustainable places in which to live and work, including housing and the environment. And number 6, taking what I call a social determinants approach to prevention. So looking at lifestyle, but looking at the determinants of lifestyle, not just telling people to behave better. So those 6 domains of recommendations, we said, based on the evidence, or where action was needed to reduce health inequalities.
Now, I want to particularly focus in on the 5th area, which is the healthy and sustainable places. Tell us how Marmot cities developed as a concept.
Marmot cities developed in a way for 2 reasons, a negative reason and a positive reason. The negative reason was, well, if not much is happening at national level, we can't just sit back and wait till a national government figures out that health and well-being are rather important goals of national policy. We need to do something at the city level. The positive reason is we need to do something at the city level. In other words, cities are where the majority of people live. We talk into the concept of social determinants of health is the conditions in which people are born, grow, live, work, age, and all that happens in cities. And in fact, city government tends to be much closer to the reality of people's lives than national governments that are a bit more removed. And Coventry was the first one that said, okay, we're going to become a Marmot city. We're going to take your 6 domains of recommendations, and we're going to make that the basis for our planning in Coventry. In fact, on one of my visits to Coventry, they said, because we're a Marmot city, it helped us become the city of culture. I said, oh, come on, you say that to all the boys. This is a bit far-fetched. And they said, no, it's real, because being a Marmot city means we all work together. We bring the different sectors together. We relate to community groups. We're trying to improve the quality of life for everybody in our city. And that was part of our bid to become a city of culture.
And a very successful city of culture it seems to have become.
Yeah.
One of the, I mean, it's interesting because most of our work is on cultural planning and cultural development, and we are also feeding in your work into our future planning as well. And I'll come back to Bristol in a moment, because Bristol is the third area I wanted to look at as examples of your cities. But the second is a much bigger area. It's the Greater Manchester region, which has obviously been in the news more recently. Tell us about the Greater Manchester area, the kind of pressures it's under, the kind of poverty it has.
Well, Greater Manchester is very interesting for a whole variety of reasons. One is it illustrates the importance of leadership, but leadership is not enough. So Andy Burnham, the mayor of Greater Manchester, I went to see him, and it didn't take too much convincing. He was Secretary of State for Health when I delivered the Marmot Review, Fair Society, Healthy Lives, in 2010. And he said one of his big disappointments of being voted out of office, of being in the opposition, was that he never got to implement my recommendations. And he said, I think we can do this at the level of Greater Manchester. Secondly, it's interesting because every sector in Greater Manchester was enthusiastic about what we were doing in working with them. Thirdly, the challenges are enormous. The inequalities within Manchester and the disadvantage compared with the Southeast. And let me give you some statistics. I'm sorry about this, but it's rather important. I'll keep the numbers down. We published in 2010, and again, 10 years later, if you look at life expectancy, classify people by where they live, and classify where they live by level of deprivation. And we're talking obviously mainly about cities, because that's where most people live. Then what you find is a social gradient. The greater the deprivation, the shorter the life expectancy. That's true nationally. And it's true in every region of the country. But there's an interesting intersection between deprivation and region. For people in the least deprived 10%, it doesn't much matter where you live. There's very little regional difference. If you're rich, you can live anywhere, and it doesn't much matter. The greater the deprivation, the more it matters. So the disadvantage in being in the Northwest, where Manchester is, or the Northeast, where Newcastle, north of Tyne, Gateshead are, increases. That disadvantage increases the greater the deprivation. It's much worse to be poor in the Northeast and the Northwest than it is in London. So that's why the challenge of Greater Manchester was particularly big. The inequalities are huge. But Manchester has wonderful resources. I mean, the history of Manchester is special, depending on your orientation. Symphony orchestra, great newspaper, two great football teams. You know, it's got everything. The home of the Industrial Revolution. It's got a wonderful history and real civic pride. People really feel positive about Manchester. It's not second best, it's best. So it's got a lot of positive resources, but huge inequalities, great deprivation. So big challenge.
Now, what's it like working across a region as against working across a city like Coventry? I mean, because they're bringing together they're bringing together other local authorities, for example, other not the health authorities, but other players in the city, aren't they? And the region.
So it's a good question. There's, of course, identity, the 10 cities or local authorities that make up Greater Manchester, each have their own identity. They On the one hand, they feel a sense of belonging to the region. On the other hand, they have their own identity. We are Trafford, we are Stockport, we are Manchester. And I respect that. And that's important. So there's a great deal of commonality, but people want to do things their way, which is important. So the mayor of Greater Manchester has an important leadership role, but the practical actions in general happen at the level of local authority or city. So it's an interesting dance, and the mayor leads by charisma, by vision, and he does, and that's very important. But for example, we work closely with the chief executive of Manchester City Council and the leader, the political leader of the council, and others from other of the 9 local authorities were also heavily involved.
The third city I want to talk about is our own city of Bristol. What involvement have you had there?
Much less, actually, much less. We've been approached by a number of cities and regions, local authorities, but we've had much less detailed engagement with Bristol. I've given lectures and the like, but we haven't done the kind of detailed work with Bristol that we've done with Greater Manchester, and we're doing with Cheshire and Merseyside, and we just launched with Lancashire and South Cumbria. So we've not done that with Bristol, but make me an offer.
Well, we'll come back to you on that. Maybe that'll be one of the key recommendations of our day that we can talk about. Now, your review there's been subsequent reviews and so on, of which you've been quite disappointed with the progress in some respects. The lost decade, you called it, about England over the last 10 years. Tell us a little bit about what's subsequently happened in your review work.
Well, we published the original Fair Society Healthy Lives in February 2010. And in February 2020, we published a 10-year look at what had happened in the previous decade, what had happened since I made this set of recommendations that would improve health and reduce inequalities in health. And what happened was intensely disappointing. And as you said, my simple summary was, we've lost a decade. If you look at the improvement in life expectancy in England as a whole, for about 100 years, life expectancy improved 1 year every 4 years, 6 hours every 24 hours. That's astonishing, amazing, incredible. And in 2010-11, that slowed dramatically and just about ground to a halt. So the question is, what happened in 2010? Well, we had a new government, a conservative-led coalition government. They said, surely you couldn't be alleging that it was anything we did that could have led to this slowdown. We said, well, we need to look at it. Maybe, they said, we've just reached peak life expectancy. It's got to slow sometime. Yeah, okay. So we looked at what had happened in other rich countries. And we had the slowest rate of improvement of any rich country except Iceland and the United States. So no, we had not reached peak life expectancy. Something had gone on in England and the UK more generally that was more marked than in any other country except Iceland and the US. Second, the social gradient in life expectancy that I described a few moments ago got steeper. The gap between the least deprived 10% and the most deprived 10% got bigger. Inequalities were increasing. And third, I've described it matters a great deal where you live in the country, as well as the level of deprivation. For the most deprived 10%, life expectancy went down in every region except London. Wow. Health stopped improving, inequalities in health got bigger, and health for the poorest people got worse. And that was before the pandemic. And then our Build Back Fair report, 10 months later, looked at the impact of the pandemic. And as was predictable, the pandemic exposed the underlying inequalities in society and amplified them. So both the pandemic and the societal response to the pandemic amplified the inequalities. And again, to come back to Manchester, a place like Greater Manchester, Liverpool, people found it very difficult to isolate because they had very little financial support to isolate. If they'd been working, they were told to go home for 10 days and were going to lose pay. They couldn't eat. They couldn't feed their children. So people didn't want to come forward for testing because if they were found to be positive, they'd have to go and isolate and then they'd lose pay. And we pointed out so then we did a third report, which was Build Back Fairer in Greater Manchester. So based on our Manchester work, I have to tell you this, the front page of The Guardian on the 30th of June had two stories. England 2, Germany 0. Jaw-dropping fall in life expectancy. As an American colleague said, both stories were jaw-dropping. But the jaw-dropping, that cliche came from me, unfortunately. That was in our Greater Manchester report. Life expectancy went down by 1.6 years for men in 2020, 1.2 years for women. Now, there was a staggering drop in England as a whole, but a bigger drop in life expectancy in Greater Manchester in 2020. And the mortality from COVID-19 in the Northwest was 25% higher than the England average. So what we were seeing in the decade up to the pandemic was not good. And we think that related to policies of austerity, disinvestment in public services, increased social and economic inequalities. And then the pandemic came and made everything worse. And that's why we called our reports Build Back Fairer, not just Build Back Better, but fairer. Put equity, fairness at the heart of all policy, whether it's at the city level, the regional level, the national level.
And certainly when you review what Coventry has done, they're very clear that they've made great steps forward, but in the face of quite staggering cuts in their budgets, actually.
What we documented was from 2010 on, the spend per person by local authorities, including cities, went down dramatically, but the fall related to the degree of deprivation. So if you divide local authorities into quintiles, 20%, in the least deprived 20%, the spend per person went down by 16%. And then the greater the deprivation, the greater the reduction. In the most deprived quintile, the spend per person went down by 32%. So this is not just austerity, but this is regressive policies. It's punishing the poor for being poor.
Can I ask you about one of the criticisms of this country, of England, certainly, is it's over-centralised and there's very little joined up government. For example, who has responsibility for urban health? Is it the Department of Health? Is it the Department of the Environment and so on? What kind of, and you look at the kind of powers that, say, an Andy Burnham has, and he would argue he still doesn't have enough, but the powers he has, that's against a Mayor Rees in Bristol. How important in developing this approach is further devolution and further extension of financial powers?
I mean, some people are ideological about devolution. I'm not ideological about it. Uh, Involving communities is vital. Local organizations, the voluntary and community sector, but involving people is vital. And more action at city level is more likely to be conducive to involving people, to co-production partnerships. I think one of the issues, as you and I have both touched on, is the mayor of Greater Manchester, the mayor of North of Tyne Combined Authority, doesn't control budgets, really. The budgets are controlled from Westminster. So how much money they have to spend is very much influenced by Westminster. So there's a lot they can do, and there's a lot they are doing. And when I had a meeting and I mentioned that we'd been working with GM, Greater Manchester, and Gateshead, the very next day, I get a phone call from the mayor's office from the North of Tyne Combined Authority. We'd like to talk to you. If you're working with Gateshead from the other side of the Tyne, then we'd like to talk to you from North of Tyne Combined Authority. So that's great. And they really can set the pattern, but they do need more control over resources.
When you look at other places, not just in England, say, are there other cities that really, or other regions that really inspire you in terms of what they've done, really around the world, I guess?
Well, let me stick with Europe for a moment. I was invited before lockdown, so you have to add a year and a half to everything. I was invited to Trieste because they told me that Trieste was an Italian marmot city. And what? When I got there, I said, "Are you a marmot city?" They said, "Who? You mean you just said that to get me here?" Well, of course, but it worked, didn't it? Well, yeah, it did. But what they were doing was inspiring. I think they talked about it as a nano approach. So they looked at very small areas of the city, and they had people representing healthcare, social services, and education, including preschool education, working together at this very local level in the city. And they're terrific people, just terrific. As you may know, Trieste is where the movement to close the long-stay mental institutions began. And so coming out of the closure of the mental institutions, they developed community resources, because you can't just close a mental hospital and say, well, you know, sleep on the streets, you're on your own now. You've got to put something in its place. And they put community resources in its place. So it was important. And I was really impressed. Then I got invited to Bologna with the same trick. You've got to come to Bologna. It's an Italian marmot city. Well, okay, it's not, but it's impressive. And when I went to talk and meet people, they were celebrating 100 years, a centenary of social welfare in Bologna. And Bologna describes itself, it's red because of its buildings, it's red because of its food, and it's red because of its politics. So they describe themselves as rosso, I can't say it in Italian, and probably because of its wine too. And again, inspiring that what they're doing at city level and getting local groups together is terrific. And then you go further afield. I've been told, don't believe all the hype, but Medellin in Colombia, as say some people have said, don't believe all the hype, but okay, may not be as good as it sounds. But when they dealt with the drug cartels in Medellin, which had a huge influence, And they put real effort into trying to revitalize the city of Medellin, that it should be a city that was good for people to live in, not just a city for organized crime to flourish in. And they changed it. So there are examples from around the world where things are happening at the city level.
I want to finally just return to COVID. You've talked about the effects of COVID on life expectancy and so on. What can we learn from both the scientific approach to COVID and also the political and economic failings of COVID and the response to it?
The first thing is I talked to a lot of different disease-specific groups, and I was talking to International Dental Meeting. So I put up 2 slides showing the social gradient. So once again, you classify people by level of deprivation, local areas, deciles, and then on the y-axis, you have level of ill health. And these 2 slides showing the social gradient. But I didn't label the y-axis. But as I was talking to dentists, one slide was decayed, missing, and filled teeth in children, oral health. The more deprived, the more caries children have. And the other slide was mortality from COVID-19. Identical social gradient. And then I was talking to a heart disease group, primary care prevention of heart disease. So I put up a 3rd slide. The 3rd slide was childhood obesity, showed the same social gradient. What's going on here? We think COVID's caused by a virus. We think dental caries is caused by diet and poor oral hygiene. We think that childhood obesity is related to diet and whatever, and they show identical social gradients. So it suggests that we've got to have at least 2 approaches to COVID. One is to control the virus, to control transmission, whether that's vaccination, social distancing, all the things that need to be done. And that's very important. And in relation to your question about how did we handle it, I reviewed Jeremy Farrar's book, Spike, for the FT. Jeremy Farrar is director of the Wellcome Trust, a well-known international infectious disease control specialist, and a member of SAGE, the Scientific Advisory Group on Emergencies. And his complaint was that the government didn't follow their advice. They knew what to do to control the virus. Initially, they didn't know what to do. It was new. And they thought, well, you could lock down in China. You couldn't lock down in Europe. Then Italy did it. Italy locked down. My goodness, maybe we can lock down in Europe. And so SAGE recommended that we lock down, and the government didn't want to do it. So they delayed. And that's been the story. On so-called Freedom Day, was it the 19th of July when all restrictions were lifted? There were 46,000 new cases of COVID. In Australia, when they've got 1,000 cases, they've been locked down for weeks, 1,000 daily cases. Well, okay, that was a post-Euro football thingamajig to have 46,000. Now it's only 30,000 cases a day. And the government can't quite decide whether it's saying no restrictions or be sensible, or we might have restrictions, or it's all over, or it's not all over, or what are they? This is about as confused messaging. So I go into shops if I have to with a mask. And it used to be everybody else had a mask. Now the people serving don't seem to have masks. And some people, the customers, some do, some don't. It's all a bit confused. So One thing is controlling the virus properly. The second is dealing with the inequalities, whether it's dental caries, childhood obesity, or COVID-19, dealing with the inequalities. And let me give you another set of figures, which I think are very revealing. We had, in the first half of 2020, the highest excess mortality during COVID-19 of any rich country. Now, excess mortality, because countries assign cause of death differently, it's a bit difficult to make comparisons of COVID mortality. Excess mortality asks, how many deaths would you have predicted in 2020 based on the previous 5 years? And how many did we get? And that difference is the excess. So it's largely COVID. And the excess mortality was higher in England than in Scotland, higher in Scotland than in Wales and Northern Ireland, and it was higher in the UK than in any other rich country. So there we were. The only one that was close was the United States. So there we were, pre-pandemic. We had the worst health improvement of any rich country except the United States. During the pandemic, we had the worst management of the pandemic of any rich country except possibly the United States. And I asked myself, what's the link between those two? The poor state of health pre-pandemic and the poor management of the pandemic. I think quality of governance and political culture. Second, the large social and economic inequalities. Third, the disinvestment from public services. And fourth, we weren't very healthy coming into the pandemic, which increases risk. So I think there are a lot of lessons to be learned, both from the decade up to the pandemic and what happened during it.
Thank you, Sir Michael, for joining us today. Thank you very much.
My pleasure.